Bienvenidos. Veo, bueno, se siguen conectando, pero para empezar puntuales y poder aprovechar al máximo esta hora que tenemos, le doy la bienvenida al profesor René Rizzoli, a la doctora Patricia Clark, a todos ustedes a nuestra primera sesión del Meet the Expert Online 2021. Este año nos hemos sumado al programa de seminarios globales de la IOF, Biobank. Y como les comentaba, nuestra primera sesión va a ser sobre abordaje nutricional para la prevención de fracturas. Quien nos presenta hoy es el profesor René Rizzoli, médico internista y endocrinólogo. Tiene una subespecialidad centrada en enfermedades metabólicas óseas, osteoporosis y trastornos del metabolismo mineral. Y es profesor emérito de medicina en los hospitales universitarios de Ginebra y ex jefe del servicio de enfermedades óseas. Estamos muy emocionados de contar con la presencia del profesor Rizzoli hoy. Y quien va a moderar la sesión es la doctora Patricia Clark, de México. La doctora Patricia Clark es reumatóloga y epidemióloga clínica y es miembro de nuestro Board Global de la IOF en representación de Latinoamérica también. Bienvenida, Patricia.
Muchas gracias. Bueno, pues muchas gracias. Muy buenos días a todos los que nos escuchan hoy y nos ven a través de esta pantalla en este webinar. Agradecemos mucho su presencia, sabiendo que han hecho un espacio en sus agendas para escucharnos hoy en este interesante webinar de nutrición y hueso. Hoy tendremos la oportunidad de escuchar algo más allá del calcio y la vitamina D y algunos otros minerales que tradicionalmente conocemos como esenciales para la salud del hueso. Pero durante los últimos años se ha acumulado un importante cuerpo de evidencia científica que nos apunta a otros nutrientes igual de importantes para mantener la salud de nuestros huesos, como son las proteínas y los probióticos y su interacción con la microbiota intestinal. Y para esta charla no podríamos tener a nadie mejor que al doctor René Rizzoli, un querido y respetado colega y miembro activo de nuestra familia IOF, quien es toda una autoridad en el tema y que este tópico forma parte de una de las líneas de investigación del doctor Rizzoli, en la que se encuentra ampliamente publicado y a quien, sin otra formalidad, dejo la palabra. Dear Dr. Rizzoli, once again, thank you very much to be part of this regional webinar, and with no further comments, I leave you the microphone for your talk.
Thank you very much. Muchas gracias. Buenos días, bom dia, good morning, everyone. I'd like first to thank the IOF for giving me the opportunity to share with you some new data regarding how to eat to maintain our bone in good health. First of all, my disclosure, and then I will start by this publication 2 years ago with a distinguished colleague from the IOF and SKO. And in the lifestyle recommendation, we recommended nutrition, calcium, 800, 1000 milligram a day, protein, at least 1 gram per kilogram of body weight, vitamin D, in addition to daily weight-bearing physical activity, fall prevention measures. But the question we are going to discuss today is how we came to these numbers and what are the evidence behind that. And when we talk about nutrition, you know, most of the time we are relying on observational studies, association studies, and sometimes the causal relationship is not absolutely clear, except maybe for calcium and vitamin D, for which there are as many meta-analyses as original studies. So the first issue is how accurate is the intake evaluation when we are evaluating what we are eating every day. Then, as you know, we are not eating the same foods every day, so there's some problem in the consistency of the intake over time. Then there are interaction with other factors, for instance, physical activity. We are eating more if we are working hard or doing a lot of sport. Then there are probably some individual responsiveness. It has been shown, for instance, that the response in terms of calcium was dependent on some genetics, some polymorphism in the vitamin D receptor. Then what is probably of the highest importance is to consider foods and not only nutrients, because we are eating foods and not single nutrients, particularly referring to what is called the matrix effect. Then the outcome is of interest because the importance in terms of recommendation will be different if we are dealing with fracture as compared with BTM, bone turnover marker, or bone mineral density. And then, as you know, there are some short-term, long-term effects, and the recommendation should take into consideration the duration of the follow-up. And finally, obviously, it's so difficult to run an interventional study with nutrition. This is a reason why most of the recommendations are based on association studies. But there's a danger with association study. Just an example is that one, with the number of Nobel Prize is directly proportional to cholesterol consumption. Obviously, this is an example of association which is not at all causal. Now, when we are evaluating the food intake, there are several techniques. The first one, probably the most difficult, is the Dietary. You weigh and measure, record everything you eat between 3 to 5 days, even with a scale evaluating the weight of your foods. Something which is easiest is the last 24-hour recall, with all the limitation you can imagine, since only the last day is taken into consideration. We have food frequency questionnaire, which should be tailored to the local habits. And probably the most accurate but very cumbersome is the food intake history. It takes at least 1 hour with a trained dietitian. And all of these different evaluations are relying on the memory of the subject. And particularly if we are dealing with elderly, it's difficult. Even ourselves, we probably do not remember what we have eaten yesterday or the day before. The investigator could influence by the question the subject's impression of what he or she has eaten. It should be calibrated to local food habits. Obviously, we are not eating the same in Argentina as compared with Mexico. And this raises a question about the accuracy of the intake. But despite that, and knowing all this limitation, we will try now to draw some conclusion about what we should what we should recommend to our patients. First of all, obviously, calcium and vitamin D. And as you know, there's a lot of debate about calcium and vitamin D, and probably, to make the story short, calcium alone is very unlikely to be efficacious in terms of fracture prevention. Vitamin D alone is the same. And what has been shown, and I'm presenting here the last meta-analysis, and as I said, there are at least 20 different meta-analyses with different outcomes. But the last one is that one. You see here, when we are including all the patients, and particularly elderly living in nursing homes, like the first Chapuis one, there is a 6% decrease in all type of fracture with calcium and vitamin D. And when we are focusing on hip fracture, the decrease is 16%. So it seems that at least some calcium and vitamin D for our patient has some effects in terms of fracture risk reduction. However, you are all aware of this thunderstorm many years ago by a New Zealand group claiming that the calcium supplement could increase the risk of myocardial infarction. But they recognized two things already. First of all, there was no effect when the spontaneous calcium intake was below the median, i.e. 800 milligram a day. And if you measure the calcium intake in your own patients, you know that most of them are below this level. And it's very rare to have a patient with a calcium intake above 800. And then what they recognize as well, there was absolutely no increase in myocardial risk if the calcium was of dietary origin. So when we eat calcium, there was no effect on myocardial infarction. Furthermore, this concept has been carefully looked at by this group, taking all the different long-term longitudinal studies and looking at the effect of total calcium, dietary calcium, calcium supplements, with clearly a dose response between 400 and 2400 milligram a day. And what you can see here, the risk for cardiovascular disease, cardiac, myocardial infarction, heart disease, mortality, there was absolutely no effect of calcium, irrespective of the dose of the intake of calcium. Then if we look at the second now nutrients, it's protein. And we know that particularly in the elderly, our patients are eating less protein as compared with middle age. This is reminiscent to what we call anorexia of aging. Then probably there is a reduced ability to use available protein by insulin resistance, by a decrease in absorption of amino acid. And finally, particularly in the frame of a fracture, a frame of a chronic inflammation, there is a greater need for protein. And altogether, there is a loss or decrease in protein intake, leading to a loss of functionality regarding muscle, bone, and the immune system. So in the middle-aged subjects, what is recommended, the recommended dietary allowance, RDA, is 0.8 gram per kilogram of body weight. But in the elderly, we have to increase this amount up to 1.1, even 1.3 gram per kilogram of body weight. And what does that represent? For instance, a liter of milk is 32 grams. So if you are weighing 60 kilo, then 6 times 0.8, this is 48 grams, and you will reach this amount with approximately 1.5 liters of milk. Conversely, a steak of meat of 100 grams is 20 grams of protein. Again, if you are weighing 60 milligrams, you will reach that with 2 steaks a day, or a large steak of 200 grams. So this means it's possible to reach this amount relatively easily for 0.8, but in the elderly, it's much more difficult. But what is the relationship between dietary protein intake and the fracture risk? Since this is a main question. And there are at least five recent meta-analyses, and I show you here only one of them, including 16 randomized control trials, short-term trial, 13 cohorts. And what you can see here with long-term follow-up with 6 different cohorts, you see that there was a reduction in the risk of hip fracture comparing the highest versus the lowest category of intake, amounting to 16%. So this means if you eat enough protein, you could avoid 1 out of 7 hip fracture. But the question now is also, what are the mechanisms involved? So one of the mechanisms is, we know that with enough protein, our muscle function is better, but it seems that the bone itself is affected. And here is a study looking not at bone mineral density, not at bone microstructure, but at a calculated estimation of bone strength, i.e. failure load, both at the distal radius and distal tibia. And here the patients, the subjects, were divided into 3 tertiles according to the level of protein intake as evaluated with a frequentry questionnaire. And what you can see here, there was, at least in the first line, a dose-response relationship. The higher the protein intake, the higher bone strength. And this was true for animal protein, dairy protein, and animal non-dairy protein. But at least in this study, it was not possible to detect the same relationship with protein of vegetable origin, but this doesn't mean that the protein from the vegetable origin do not play a role. But at least in this study, it was not possible to detect it. Now, when we are discussing protein, as you know, there's an old concept saying that a lot of protein is metabolized into acid, and this acid could resorb bone. And this concept is mainly based on in animal studies, but in human, it's relatively difficult to confirm it. And at least in this paper, you see here a follow-up over 6 years, 700 healthy subjects, and they were divided into a diet with so-called alkaline diet, a neutral diet, or an acidic diet, and this was determined by measuring the so-called PRAL for potential acid, dietary acid load. And you can see here that in gray, these are the women, in dark, nearly black, the men. So there was no bad effect in the acidic group. If anything, they were a little bit less affected, but the age-related bone loss at different sites, different compartments for radius total BMD, radius cortical BMD, radius cortical area, radius cortical thickness, there was no clear bad, negative, deleterious effect when the diet was considered as acidic. So this means that at least within a normal diet, this concept is not confirmed. But we are eating not only protein, but we are eating foods. And among all the different studies having looked at the effect or the interaction or the association between dietary intakes of protein and fracture risk, there were at least 2 concluding to a deleterious effect of protein. And this is the first one in France, with a higher risk of fracture, all type of fracture 1.5. And the second one in Boston, here 2.8, but this only if the calcium intake was low. When in the same trial, they look at the effect of the protein in the presence of a sufficient calcium intake, there was no negative, no deleterious effect. So this asks the question, what is the source of both calcium and protein? And this source is obviously the dairy products. And now we are moving from nutrients to food, trying to integrate all the nutrients contained in food. And here you see some information you are all very well aware of, that the milk, normal milk, is approximately 1,200 milligrams of calcium. And in terms of protein, it's between 3.32 to 34 grams per liter. And as you know, from one car to the other, from one season to the other, from food to the other, the milk content of the different nutrients could vary. But there is some standardization, and the milk you are buying in the shop is standardized, trying to keep exactly the same amount, irrespective of the season and irrespective of the cow strains. Now, there is, in particular in certain countries, not in Europe, but particularly in the US, the yogurt, which is, as you know, all of you have probably once prepared some yogurt. The yogurt is just like plain milk. And the content of calcium and protein should be exactly the same. But for some reason, to have the yogurt a little bit more sticky, denser, in some countries, they are adding some powder of milk. And this is for the reason in this table here that the calcium and protein content in yogurt is higher as compared with milk. Now, if you look at the cheese, obviously, particularly hard cheese like cheddar or Swiss cheese, this is a major source of calcium and of protein. And nowadays we could estimate that in somebody eating a balanced diet, the dairy products represent at least 50% of the intake of calcium and probably 25 to 30% of the intake of protein per day. But the question now is it possible to get the same calcium not from dairy products, but from vegetables? And the question is certainly yes, but with the caveat that, first of all, depending on the vegetables, the calcium is not in a form absorbable by the gut because it's complex, for instance, with oxalate. But then to reach the same amount of calcium as compared with dairy products, you need to eat a lot of different servings a day. And here, for one serving of 250 milligrams of calcium, which is, as we said, the fourth of the recommended daily allowance of calcium, we should eat every day at least 5 servings of dine green leafy or 6 servings of legumes. So it's obviously not possible to replace something as easy as the dairy products with every day the same amount of calcium provided by vegetables. And the same is true if you look at grain group, whole grain or refined grain group, you should eat at least 10 servings a day to provide enough calcium. Now the question is, what happens if we are avoiding any dairy products, like in the vegan diet? As you know, vegetarians could be sometimes could take some dairy products, but the vegans are just excluding any dairy products from the diet. And this is a meta-analysis 2 years ago. And if you look what is highlighted in red, those individuals switching to a strict vegan diet have a higher risk of fracture, a 40% increase, 1.4-fold increase in the risk of fracture. And this is true both in Caucasian and Asians. But this doesn't mean that if you are accustomed to this diet since several generations, that the risk is the same. But this means that if you switch suddenly from a balanced diet, including dairy products, to a diet absolutely devoid of any dairy products, in this case, you increase your risk of fracture. Regarding now all the different trials, having looked at the association between the risk of fracture and dairy products, there are recently at least 5 different meta-analyses. But as you know, you include in your meta-analysis the different studies you are friend with, what you consider as fulfilling the condition to be included. And you see here from these different meta-analyses, some are including only 5 cohorts, some up to 14 cohorts, and the last one was focusing only on fermented dairy products and included only 3 cohorts. But if you look overall, with milk, yogurt, cheese, and all kinds of dairies, if anything, the number in terms of relative risk is lower than 1, indicating that sometimes it's significant when it's bold and with an asterisk, sometimes it's not significant, but overall, there is some favorable association between the consumption of dairy products and the lower risk of fracture. But one of the questions you could ask, what about milk and what about fermented dairy products? And in this study here, which was like a drama several years ago, this Swedish group concluding to a very bad effect of milk on fracture and on mortality. But in the same paper, in the same cohorts, they look specifically to the effect of fermented dairy products like yogurts and cheese. And what you can see here, there was clearly a dose-dependent relationship. So the higher the intake of fermented dairy products, the lower the risk of hip fracture. And you can quantify that for a 200-gram yogurt, there was a 10 to 15% reduction in the risk of hip fracture. So fermented dairy products could be beneficial even in this study where milk was not as good as expected. And in terms of mechanism now, looking once again to not to bone mineral density alone, but to some macrostructural component, you see here in this longitudinal study, the subjects older than 65 years of age were divided into those eating less than 1 yogurt a week. This is a dark column. Between 1 and 6 yogurt a week, the gray column, and those with at least 1 yogurt a day, the white column. And what you can see here, there was clearly a reduction in the age-associated decrease in, for instance, C, cortical volumetric bone mineral density in those subjects eating at least 1 yogurt a day. And now if we try to summarize what could provide the fermented dairy products, there is some calcium on the left-hand side. As you might expect, more calcium, higher absorption, and we need some mineral calcium and phosphorus for bone mineralization. On the right-hand side, you have the proteins, and we know particularly the amino acid, aromatic amino acid, are stimulating the production of the hormone IGF-1, and this is associated with an increase in bone formation. And then fermented dairy products could provide some prebiotics. You will see later the effect of prebiotics. Prebiotics are sugar not absorbed or metabolized in the small intestine, but metabolized in the large intestine, leading to the production of some short-chain fatty acid. And probiotics are bacteria, when given in sufficient amount, could have some health-promoting effect. So altogether, fermented dairy products could fulfill these 4 different conditions. But one of the questions you could ask, we have heard that fat, dairy products could be so bad for the heart. And probably this is when you consider only the fatty acid. But once again, if you consider the foods, the so-called matrix effect, it's not so easy to confirm the bad effect of dairy products on the heart. This is one of the several examples, a long-term study in 21 countries from 5 continents, prospective cohort, and they looked here at the mortality or the major cardiovascular disease when protein was dairy source. And if anything, the dots are on the left side of the vertical line, suggesting that there is probably not a protection, but at least no deleterious effect. The dot is not the right side. And if you look now at the bottom of the slide, when they try to look at the countries or regions with a low intake or high spontaneous intake of dairy products, you see here there was clearly a dose-dependent relationship. With more than 2 servings a day, there was less mortality than those with no dairy products per day. So the dairy products, as you have seen up to now, are good for the bone, and maybe they are not so bad for the cardiovascular system. And this is probably has been shown for not for centuries, but for several thousand years. And maybe you have read that in some pottery in Turkey or in Yugoslavia, it was possible to detect some dairy products traces. But this was in pottery. And this paper, which just came out, is something which is a better proof that they found some milk protein not in the potteries, but in the dental calculus of a skeleton found in Africa. And some of the skeleton were as old as 8,000 years before Christus. So this means that there was the possibility now for 9,000 years to eat some dairy products, and if they were so bad, people who would have probably given up to take this type of food. And the next question is, what about, is it possible to replace the dairy product by what we can find in the shop, like the rice drink, oat drink, and so on? And the answer is probably it's not so easy despite all the advertisement. Because if you look here at the protein, at the carbohydrate or calcium content, highlighted in red, on the left-hand side, this is what we've seen before, the milk intake, the milk content. Now the second column is the soy drink or soy milk. And by the way, now soy drink is the only preparation which has been allowed to take the name of milk, although it's not a milk. So you see that the protein content is similar to milk. You see the last line, calcium is relatively similar as far as soy drink fortified is concerned. But if you look at soy drink, there's nearly no calcium. So this means that all these different preparations could be similar to milk only if there is some chemical additions. And this is very clear. Now, on the right-hand side of this slide, these are the other drinks, almond, rice, and so on. And here you see they are nearly devoid of protein. The calcium content relies, this is the third highlighted red line, relies on chemical addition. But to maintain this different preparation isocaloric, how they are doing that is by adding sugar. So you could cast some doubt about the safety and the healthy characteristic of these drinks, both by adding some minerals to try to be as comparable with milk, and second of all, to replace the low protein derived calories by sugar in this preparation. Now, the next question is, after calcium, protein, the way to eat enough calcium protein with all the matrix effect of dairy products, I was alluding to the so-called prebiotic concept. And here you see that the different fibers we are eating every day are producing what we call short-chain fatty acid, like butyrate, acetate, or propionate. And depending on the source of the fiber, you could have a lot of red, for instance, with resistant starch, or a lot of green, last line, like soluble fiber in pectin. And then these different fatty acids could have some local effect on the gut, but they could be absorbed and have some effect elsewhere in the body. And I will show you here, it will be the only study in animals, but it's very spectacular. They did here, they took animals, mice, then they induced a menopause with ovariectomy, and this is a second NT, so this is ovariectomized animal with much less bone. And then they give in the drinking water some acetate, propionate, or butyrate, C4. And what you can see in the first series of pictures, that giving C4 to these animals with ovariectomy, it's possible to nearly prevent the bone loss induced by the sex hormone deprivation. And the treatment here lasted 8 weeks. So this is very promising. Now, what are the evidence in human? In human, there are here, this is a large study derived from the UK Biobank. And here, bone mineral density was evaluated with a very indirect way. It was BMD similarity, so it was an ultrasound equipment. But what is interesting here is the conclusion of this very large study. Greater intakes of total dietary fiber and subtypes from various food sources are associated with a higher yield BMD. So this means that eating more fibers, you have more bone. And the question is, like before for protein, what happens if we don't eat any fiber? And this has been shown here in a longitudinal study. Here you see the risk of hip fracture depending on the number of servings per day of fruit and vegetables, which are the source of fiber, with a pretty large number of men and women, long follow-up, 14.2 years. And what you can see here, if you are eating less than 5 servings a day, which is the number recommended usually, you have an exponential increase in the risk of hip fracture. And this is true for fruits, it's true for vegetable as well. And these various long-term longitudinal studies have been combined in a meta-analysis. And you see here 5 different studies, and all together, there was an 8% reduction in the risk of hip fracture with a higher intake of food and vegetables, including some fiber, providing some fibers. But as I said, most of these observations are coming from observational studies. And when you want to do an interventional study, it's very difficult. I found here 4 interventional studies with fruit and vegetables, only 3-month duration, with the bone turnover marker CTX only as the outcome, with very few patients, and altogether there was no difference, emphasizing the difficulty to have a randomized control trial assessing the effect of food on a bone-related outcome. Now, the next question is, how is it possible to combine everything? So you combine some fibers from vegetables and fruit, some dairy products, and a little bit less of fish, poultry, and so on. And this is associated with regular physical activity. This is combined in the so-called Mediterranean diet. And the question has been asked, what is the association between Mediterranean diet and the risk of fracture? And I show you here 2 different studies, one on the left-hand side in Sweden, the other one on the right-hand side in the US. And what you can see here, with the higher adherence to a Mediterranean diet evaluated by a score, there was clearly a reduction in the risk of hip fracture. On the right-hand side, it's the same. Taking those with a score less than 2 as the reference, you see that with a score of 5, you have a 20% reduction in the risk of hip fracture. And this was associated with a well-known effect on the cardiovascular risk with a higher gut microbiota diversity, lower cholesterol, lower inflammation, and lower insulin resistance. And the effect of the Mediterranean diet in these 2 studies you have seen previously have been now associated with 2 other studies, and altogether this indicates that the risk of fracture is lower in those patients adhering to a Mediterranean diet. And this is not only in Greece, where the Mediterranean came from, but you have seen the data in Sweden, you have seen the data in the US. And this meta-analysis included more than 300,000 patients. There were more than 6,000 hip fracture. And on the bottom of the slide, once again, there is clearly a dose-response relationship. The higher the adherence to the Mediterranean diet, the lower the risk of hip fracture. So, ladies and gentlemen, now it's time to conclude. And what are the take-home message? What should we recommend to our patient to try to reduce the risk of osteoporosis and the risk of fracture? The easiest is a balanced diet, including enough protein, but a little bit more in the elderly. Here the number of 1.3 grams per kilogram of body weight is mentioned. Enough calcium, 800, 1,000 milligrams a day, and enough fruit and vegetables, at least 5 servings a day. Part of this protein, as I said, and calcium could be provided by dairy products, and there are some recommendations for 2 to 3 servings a day of dairy products. I hadn't time to go into this, but we should limit the sodium intake. Vitamin D, 800, 1,000 units a day. And one dietary pattern shown to be associated with a lower fracture risk, such as, for instance, a Mediterranean diet. So I thank you very much for your attention. And I remind you the Virtual Congress, the World Congress of Osteoporosis, which will be held in August, the next one in Berlin, the next one in Barcelona. But if you want to send an abstract, the deadline is May 26th. So in 1 month from now. Thank you very much for your attention.